Hello and welcome. Today we're going to focus on an aspect of ovarian pathology that is not infrequently encountered and can present some differential diagnostic problems. It's something that I think every pathology trainee needs to be aware of and understand some of the patterns. And that is the presence and occurrence of metastatic disease involving the ovary. So our goal with this is to allow you to understand and see some of the lesions that can present in this manner and understand some of the patterns that can be seen. So for example, one of the things that we have to be aware of is the issue of mimicry. While this is very common in nature, both in the insect, animal, and plant world, it's also true in the body. And there are a variety of patterns that can be seen where metastatic disease can mimic neoplasms that occur normally or otherwise primarily in the ovary. I've divided these into four different patterns. One is the solid fibroma-like pattern, which is characteristic of certainly the Krukenberg type tumors and lobular breast cancer. The mixed solid and cystic pattern, which can mimic either sex-cord stromal, high-grade serous, or even teratomatous lesions. And that can include metastasis from other gynecologic sites like the endometrium, as well as some GI sites and renal tumors. And then the mostly cystic tumors that can be particularly difficult in the mucinous category, less so in the serous type lesions. And these usually are confined to the differentiating the colorectal and appendiceal lesions. And then finally, we have the sort of insular and tubular patterns that can mimic both a Sertoli-Leidig tumor, occasionally endometrioid carcinoma, and carcinoid tumors themselves. One of the things that's very important to remember is that gross examination can be quite helpful. It's not an absolute criteria, but it certainly can be very useful to recognize certain features that favor one or the other. So for example, metastatic tumors are commonly bilateral, and they're usually relatively smaller, although obviously there are notable exceptions up to 30 and 40 centimeters occasionally. Surface involvement is more characteristically seen in metastatic disease than in primary tumors, particularly if there are separate lesions on the fallopian tube that may indicate that there's sort of a multi-site type of metastatic pattern. However, it's also important to remember that there are a number of cases and a number of syndromes where the primary presentation of a tumor is in a metastatic stage involving the ovary. So particularly appendiceal and a significant portion of colorectal tumors, as well as occasional renal and breast tumors may present initially as the first presentation or first awareness of the disease in the form of an ovarian metastasis. Of course, that's very disconcerting for the patient, but it's even more embarrassing for the pathologist if you mistake that primary ovarian tumor or that tumor for a primary ovarian type tumor. So with that, let's express some appreciation first off for our radiologic colleagues who can oftentimes be helpful. And this is one example where, large pelvic masses here and seen both in cross-section and otherwise. And then PET scanning shows up, in addition to the pelvic lesions, a nice lesion involving the stomach, as well as metastatic disease in other sites, in the bones and so forth. So this then ceased to become so much a diagnostic problem as just a management problem in terms of how to control the disease and allow for some salvage of lifespan. So the tissue that seemed to be most accessible was a radiographically obtained biopsy of the pelvic mass, and this is what we found with that. As you can see, we have sort of a core of ovarian type tissue, and within this tissue are a number of fragmented and small glandular structures, somewhat interspersed in the tissue. Occasionally, there's a little bit of luminal debris, and also we see some evidence of intraluminal mucin in several of these. This is not a classical signet ring type cancer, of course, but illustrates that this small glandular pattern can be seen in enteric metastases, in this case from the stomach primary. And of course, with this tissue, other ancillary studies of value like HER2, maybe MMR or other targeted therapy considerations can be resolved using tissue of this sort. Now, this is another example of a gastric cancer metastatic to the ovary. But this is a nice example of how a very diffuse pattern can appear on these lesions. At low magnification, we see a few dilated vessels, but a very solid appearing neoplasm. And even as we come into higher magnification, we see that there's really a lot of stromal appearance. So if you just did a low power and maybe intermediate pattern, power pattern, you might be tempted to say, oh, fibroma, fibrothecoma type of lesion. We see a bit of a storiform pattern here. And it's really not until you get into much higher magnification that you begin to appreciate that there are some atypical nuclei in this storiform lesion. And as we go even a little higher magnification, we can see there are some vacuolar structures which tend to displace the nuclei. And notice how few tumor cells are in certain areas of this high magnification view. So it could be very easy to gloss over this as just maybe a fibroma with slight atypia or something. If we didn't either take the time to identify these signet ring atypical cells or do immunohistochemistry or histochemistry for mucin to identify the presence of these tumor cells in this very insidious infiltrative pattern amidst a fibrotic stroma. So this pattern of fibroma-like can be repeated in a number of circumstances, but is probably the most frequently seen in this disseminated signet ring cell carcinomas that can be so difficult to detect intraperitoneally, even in the primary location, because they don't tend to form a discrete mass, but instead present with a linitis plastica appearance or an infiltrative pseudo-inflammatory type pattern. Here's another pattern that also similarly sort of tends to mimic a primary ovarian tumor. It's a solid lesion. We have a lobulated architecture with intervening areas of more edematous type tissue. And so at low magnification, this can look a little bit like a sclerosing stromal tumor or perhaps edema or something of that sort. But as we come into higher magnification, and I apologize that the staining is not a little bit more robust here, it's a fairly pale stain, not from our laboratory, but we begin to see that there's this sort of nested or floret type of pattern to many of these cells, and on high magnification we see that the cytoplasm is very pale, but almost all of the nuclei are pushed to the side. So in this case, the mucin droplets are not staining with a clear type pattern. They are taking on the eosin and having a very eosinophilic appearance, giving you this pattern. Now, it is important to recognize that there are stromal tumors that can have signet ring cells. So there's a signet ring stromal neoplasm that can have a very signet ring type pattern. I don't have one of those to show in comparison, but it can have this kind of lobulated architecture in some circumstances. So you have to be wary of that mimic as well, that between these two lesions, you might be confused on pure H&E grounds. Immunohistochemistry, of course, will highlight the epithelial nature of these cells, which would not be true in a signet ring stromal cell tumor. Here's another pattern that can be seen in this metastatic disease pattern. And notice here that it has this sort of anastomosing chorded pattern that looks at low magnification very much like a pseudovascular pattern with little strands of interconnecting tissue that look very reminiscent of small vessels. However, on higher magnification, we can appreciate that these are not strictly vascular structures, but in fact, many of them are associated with little clusters of, again, signet ring cells. So this signet ring discohesive type carcinoma can be very subtle in its presentation and in its efforts to mimic the tumor or to mimic other processes. The interspersed tissue can be variably edematous, fibrotic, or even mucinous appearing in some circumstances. And we'll look at that in this example. Here's another case with, again, sort of this lobulated nested pattern with this peculiar peripheral accentuation around these nests. As we come into higher magnification here, we see what is causing this is that there is a tremendous amount of mucin within the stroma here that is separating the collagen. And so this is a described pattern known as filamentous or a filigree type of degenerative change. But it's associated with, as we see here, these very dilated signet ring cells that are characterized as a carcinoma. And they're sort of condensing at the periphery of these nests, but with this filamentous or filigree pattern, essentially pseudomyxoma ovarii involving and dissecting between the stroma of the ovary. So this pattern of sort of dissecting mucinosis or pseudomyxoma ovarii can also be a pattern somewhat resembling the other lesions that can occur in the ovary. So let's go on to a different, well, no, actually, we've dealt with the gastrointestinal lesions. Let's see how other tumors might also produce this pattern. Here is a very solid pattern, very eosinophilic, fibrotic type of appearance, a little bit of streaming, banding of tissue. And so again, it looks much like various fibromatous type of lesions that we can see in the ovary. However, in this particular situation, as we come into higher magnification, we see that there's really quite a lot of epithelioid type cells in this pattern. We see some atypical cells, rounded nuclei, prominent nucleoli, a little bit of pale eosinophilic and slightly fibrillary cytoplasm. And we note that there's a little bit of lining up of some of these cells as they sort of tend to form little Indian file groupings. This is one of the patterns of metastatic lobular carcinoma of the breast involving the ovary. And so as we saw, at low magnification, you might mistake it for a fibroma. But for finding the mitotic figures, the atypia, the epithelioid morphology that underlies this pattern, you could easily miss it. Here again, of course, markers may be somewhat deceptive because obviously hormonal markers may be positive in these metastatic breast cancers, although your stromal markers and so forth would, of course, be negative. This also is metastatic breast cancer, and you can see again it's a fairly solid pattern, but not one that's likely to be too easily mistaken for a primary ovarian tumor. Here we have this sort of sieve-like pattern of small tubular structures with intervening almost scirrhous fibrotic tissue. And as we come into higher magnification, we can see that this very busy tissue is a lot of very small, irregular glandular structures with variable nuclear atypia, not high-grade atypia, but sort of moderate, and some intraluminal mucin. So this pattern could be seen with a GI tumor, maybe a gallbladder tumor or other types of cancers, but in this case was originating from a ductal breast carcinoma. And again, hormone markers can be deceptive here if you're using that as your main discriminant. So here's another pattern, more cellular tumor, a bit lobulated, a lot of maybe suggestion of necrosis or hemorrhage in this tumor. And as we come into higher magnification, we can appreciate that some of these cells have fairly clear cytoplasm, very distinct cell borders for many of these cells. And by golly, you say, well, you can have clear cell carcinomas in the ovary, so this must be a clear cell carcinoma of the ovary. And it's surrounded by subtending vessels and so forth. And while that's true, while you can have this solid pattern of clear cell carcinoma is certainly not the most common in breast carcinoma, in ovarian carcinomas of the clear cell type. So realizing that clear cell tumors can originate elsewhere, it might be good in a more solid pattern like this to consider the possibility of a metastatic clear cell carcinoma of renal origin. Recognizing that in this circumstance, stain like PAX8 will not be a useful discriminant, as many of those renal tumors can be also PAX8 positive. So other markers such as concomitant cytokeratin and vimentin expression and maybe CD10 expression could be more useful in defining this as being of renal origin versus the napsin-A positive carcinomas of the primary carcinomas of the ovary. Well, with this, we come to the really challenging area where we have cystic lesions. And here's a lesion with obviously large cystic spaces. It's somewhat collapsed. And we can see there's a somewhat complex epithelium here. And even at this magnification, you can make out that there's obviously mucin. You probably would have also gotten that impression from the time from opening the cystic structures and seeing a viscid mucoid material pour out. So looking at this lesion under microscopy, we see that it's fairly low grade. The nuclei are all basal. The apical tips have a nice mucin droplets. So it looks very much like a maybe a borderline mucinous neoplasm that could be primary in the ovary. And this is where distinction can be very challenging. So recognizing that we have a lesion that is a mucinous tumor on frozen section is very helpful, because that really sort of mandates then that the surgeon consider other possible sites of origin, such as the appendix or colorectal tissues, especially the appendix, because virtually all of the metastatic mucinous tumors that occur in the ovary that are low grade like this are derived from appendiceal lesions. So low grade appendiceal mucinous neoplasms and occasional appendiceal mucinous carcinomas. Immunohistochemistry obviously can help you in the final diagnosis to a certain degree, notably with SAT-B2 being a marker that's positive in colorectal and appendiceal lesions, but uniformly negative in primary ovarian mucinous neoplasms. So with that consideration, let's look at some of the other lesions that can give us this impression of large cystic spaces. So here's one of these lesions, as we see large dilated spaces, some smaller spaces. Well, with this lesion, we also notice that the content of the cysts is relatively clean. It's not a dirty pattern. And so as we look at this, let's take a little higher magnification view of this. But one would expect, based on this sort of clean contents of the cysts, that we're not dealing with high-grade dysplasia. And so we'd want to ask, what's going on here? So looking at this lesion, we see here on high magnification that, we have some atypia of these cells. They're not all totally basal, but they tend to be mostly towards the basal areas. There's a little bit of nuclear atypia, and not a lot of mucinous epithelium, but some. We also notice that the stroma surrounding these lesions is sort of ovarian type fibrotic stroma. And we see, just a mild to moderate degree of cytologic atypia. A few maybe mitotic figures. We'll go over here to the more solid area in this tumor. And we see here a pattern that can be somewhat helpful, because we're seeing small nests that are infiltrating and appear to be variable in size compared to these other larger cysts. So this is uncommon for primary ovarian mucinous neoplasms to have these kinds of small branching tumors. And it raises the possibility that we've got some degree of infiltration going on in this stroma. It's a little bit subtle, but it is something that I think we should pay attention to. And then here in this area, again, this type of a pattern is a more infiltrative pattern. We see some high-grade atypia here. This is not the pattern of the usual low-grade mucinous neoplasms. So this could be an invasive mucinous carcinoma of the ovary, or in this case, it is a metastatic carcinoma derived from a pancreatic primary of a ductal type tumor with this fairly low-grade mucinous pattern neoplasia. So here is a situation where a high degree of suspicion and maybe a little bit of concern could be warranted. This would be a very easy case to mistake for a mucinous ovarian neoplasm or mucinous carcinoma of the ovary, but for just a few features that suggest metastatic disease. So we'll look at another pattern that also has fairly large cystic structures here. We see these large, almost follicle-like structures, a little bit of eosinophilic secretion, and a background of very diffuse pattern cellularity, somewhat blue cells. Even a few sort of filigreed areas. And so looking at this lesion at low magnification, one could easily begin to think juvenile granulosa cell tumor, maybe Sertoli-Leidig tumor, and think about some of those primary lesions. And those would all be very good thoughts, but for the fact that this patient is not in that age group. So in an older patient, thinking twice about those kinds of things would be important. Looking a little more closely, we can see that this even on the cytologic level, also tends to mimic a juvenile granulosa cell tumor, because we have really quite a bit of abundant cytoplasm, very eosinophilic, not a whole lot of nuclear atypia, no Col-Exner bodies, of course, no watered silk pattern for adult type. And the nuclei are mostly round. If we had maybe a little higher magnification scan, we might see even a few grooves or something of this sort. But these very eosinophilic cells, and we notice here that that many of these cell groups are invested by almost an endothelial type lining. That's not a pattern of primary ovarian tumors, but it is something that we might see in, say, a hepatocellular carcinoma. See this little overlying pattern of endothelial-like cells branching over this nest of cells here. So in fact, this is a metastatic hepatocellular carcinoma, and immunohistochemistry would be very helpful in this situation to differentiate these two. Obviously, this would be positive with HepAR1 or arginase, whereas totally negative with inhibin or any of the other sex cord stromal markers like calretinin or MART1. So this is an uncommon lesion to metastasize to the ovary, but again, I think illustrates this ability of some of these non-primary tumors to mimic the patterns that can be seen in primary ovarian carcinomas. We'll look at another one here, which has a similar sort of pattern, large cystic spaces, follicle-like, and a diffuse interstitial pattern. So this lesion also, as we try to magnify the lesion, we'll try to get there here. Well, I'm getting the uncomfortable sense that this does not want, there we go. Okay. So here we go. As we come into high magnification, we can see these sort of cystic spaces sort of falling apart. We see a pretty good degree of nuclear atypia. So again, this sort of mimics the pattern of a juvenile granulosa cell tumor. And we would wonder about that possibility. Now, the kicker in this situation is that this patient had a history of a cutaneous tumor, and this was felt to be a metastasis from a melanoma. So this underscores the need to perhaps use more than one sex cord stromal marker. Inhibin and MART1 might give you confusing results. In the sense that you might find MART1 to be positive and inhibin negative, and sometimes that happens in sex cord stromal tumors. So thinking about other sex cord stromal markers and also looking at more specific melanocytic markers in that setting, such as SOX10 or MITB, or MITF, would be useful in affirming that this is in fact metastatic melanoma. You'll notice that many of these cells have a bit of a rhabdoid appearance, and that the nucleus, in contrast to usual juvenile granulosa cell tumor, is not centrally located, but is somewhat peripherally displaced, and that the nuclei have a little bit of a clock face appearance. So let's look at one more case and one more pattern. This is an ovarian neoplasm, which again has this large follicular pattern and has cystic spaces and a peripheral rim of very hematoxyphilic cells, very blue cells. In addition, we have areas where we have sort of an insular pattern. Let's go back out to low magnification here and show, take a look at this insular pattern over here. So here we have areas where we have little islands and puzzle pieces type of pattern of cells and a more diffuse pattern. So this could be seen as a high-grade carcinoid of the ovary, neuroendocrine tumor, particularly as we get to higher magnification and see the nuclear features are fairly characteristic of that. But could also be a metastatic lesion from a neuroendocrine tumor in another site. Now, there's not a particularly good way to distinguish that aside from clinical history or clinical findings, which in this case were remarkable for an appendiceal neuroendocrine carcinoma, actually a mixed neuroendocrine adenocarcinoma. But in this case, only the neuroendocrine component had metastasized, and here in the ovary was forming this somewhat pseudofollicular pattern with areas of insular morphology. We'll go back to low power here again and let you see what this looks like at low magnification. It's not a pattern that you would usually think of for most ovarian tumors, but it has some interesting features in that regard. We'll come back to just two more cases. Here's another case of a signet ring type lesion, which I just throw in as a sort of a bonus lesion, but also noting that this has this very round nested type of pattern or tubular pattern that could be reminiscent of a Sertoli cell tumor. And so sometimes this pseudo-tubular pattern with intervening edematous areas could be reminiscent of a Sertoli Leidig tumor. And that's particularly a challenge because sometimes the stromal cells can become quite hormonally active. And so sometimes you'll be looking through the stroma in areas like this and you'll see clearly luteinized cells like these that might look very luteinized and even have features suggestive of crystalloids. And while we know that just about any tumor can provoke a luteal type stromal reaction, in fact, some colonic tumors are amongst the most frequent in doing that. So finding hormonal manifestations in a neoplasm is not to be just treated lightly. Finally, we couldn't be showing metastases from to the ovary without showing the sine qua non of these. This is the classic metastatic colorectal carcinoma, which we see here with these very tall cells and areas of sort of busy, almost dirty necrosis in the background, especially here in these sorts of areas. So we speak of these tumors as having being tall and dark cells with dirty necrosis. This is the catchphrase that's frequently used, but you can see that not every gland here has that pattern. Now, what ovarian tumors might this be mimicking? Well, some endometrioid tumors can have a very mucinous appearance, large dilated glandular structures. And so differentiating this from an endometrioid tumor would be very, very important. And especially important to do that at the time of frozen section because those are going to be worked up and staged quite differently. So what features can help you? Well, the dirty necrosis is more characteristic of colonic carcinomas. The other feature that can be found here is a little bit more subtle, but is this goblet cell type of pattern These droplet-like mucin droplets in the cytoplasm are far more characteristic of mucinous or enteric type colorectal tumors than they are of any mucin-producing endometrioid tumors. Such things do occur and can be a cause for justifiable confusion or ambiguity, but you should be very careful and cautious and be aware that these things are challenging, and you need to look very closely to see that you've gotten as much information out of your tissue as possible. So here's a representative counterexample. This is a frozen section. Obviously, we've got some artifacts, some folding, some freeze artifact here. And here we do see some mucin production from these cells. We also see extravasation of mucin. So this also is another feature that is uncommon in primary mucin-producing tumors of the ovary of endometrioid type. So seeing extracellular mucin with this degree of cellularity and the presence of obviously cytoplasmic mucin droplets is more characteristic of enteric type tumors. So making the diagnosis on frozen section of mucin-producing adenocarcinoma with occasional goblet cells and extravasated mucus would be helpful to the surgeon to exclude gastrointestinal primary lesions as the source of this tumor. Now, if this is a unilateral lesion, that may be more difficult. It may be more confusing, but still you want to do the best you can. And this is where the gross features come into play in these lesions. So I mentioned the hormonally functional stroma. This is a phrase coined by Dr. Scully, and this is most frequently seen with metastatic colonic tumors. But any tumor with a tubular cystic pattern of spread, you could see these luteinized cells potentially confusing you with a Sertoli-Leydig tumor, the Leydig cell component thereof. And with that, we have come to the conclusion of our survey of ovarian tumors. I'll post the links for these slides in the comments section, both those from Path Presenter as well as those from Second Slide, so that you can look at those at your convenience and study what's to be learned from these cases. Thank you for watching, and if you like this, please subscribe so you'll catch future releases, and maybe share it with some of your friends.